Good afternoon and welcome to Workshop 25, Glucose Care, a Spectrum of Challenges. My name is Stacy Bickle and I'm a pediatric nurse practitioner from Lurie Children's Hospital in Chicago. My co-moderator, Lisa Manick, is a registered dietitian and certified diabetic educator for the CF adult population at the Toronto Adult CF Center at St. Michael's Hospital. Neither Lisa or I have any relationships to disclose today. So, I'm excited to be part of a session that is truly North American with speakers from both Canada and the United States. And if you do a quick Google search about the similarities between us, you will find many interesting facts, including the following. For instance, the US and Canada have been friends, partners, and allies for more than 150 years, and our bilateral relationship is one of the closest and most comprehensive in the world. I think this holds true in our care of people with CF. We all want the best health for people with CF we care for, and we share many of the same challenges. We all know diabetes can negatively impact both the physical and mental health of people with CF. Yet screening for this complication is an aspect of care we struggle to provide and perhaps avoid as clinicians and people with CF alike. And I think we all hoped that highly effective modulators might reduce or even erase the need for CFRD screening. But as has been presented at this conference, the evidence for this is not there, at least not yet. And then I think we can also agree that a lot of things fell apart during the pandemic, including diabetes screening and endocrine care. You will also find that we have some differences. And again, Google will support this. For instance, Canadians are more likely to take their shoes off in the house. It will also tell you that Canadians prefer to pretend Canada has no problems, while Americans pretend the US merely just has a few quirks. Based on this, the screening and care of CFRD is either a hidden problem or just a little bit quirky. But that's why we use the term challenge. And regardless, either way, it needs attention. Finding an alliance on the optimal way for how and when to screen for CFRD and innovative ways to share in treating CFRD, that is what today is for. There are a lot of questions. The CF Foundation Consensus Guidelines with screening recommendations are dated, published in 2010. The Envision program, sponsored by the CF Foundation, has fostered increased interest in CF care from the endocrinology lens. In the Journal of CF in 2019, there was an excellent supplement on endocrine care, which I recommend that you read if you haven't yet. A second rendition of the Envision program is in progress and will add to our knowledge of CFRD. And then, of course, the number of research studies in progress and publications available on the subject are overwhelming and growing as we learn more about endocrine care in the era of highly effective modulators. But the questions remain. How are we really doing with our screening? And does a one-size-fits-all screening process really work? Can we stratify risk for CFRD screening? Are there acceptable substitutes to the dreaded OGTT testing? Could we use hemoglobin A1Cs or fasting glucose alone or continuous glucose monitoring? And then is once yearly the right interval? Is 10 years of age the right threshold? And then more questions about optimal management. Are we using all the available technology in the care of CF diabetes? So those are some of the questions we will approach today. Our first speaker is Dr. Rebecca Hicks. She is a health science assistant clinical professor at the University of California in Los Angeles, as well as the medical director of the Miller Children's Hospital in Long Beach. She provides endocrinology consultations in both affiliated pediatric centers. Along with her husband and 3 boys, Dr. Hicks has seen all of the Marvel Universe and Star Wars movies and series. Today, she will be presenting from a North American survey of CFRD screening practices. Welcome, Dr. Hicks.
Hello, everyone. Today I'm presenting on a North American provider survey of cystic fibrosis-related diabetes screening practices. I received grant funding from the CF Foundation, but I have no other disclosures. Cystic fibrosis-related diabetes, or CFRD, is highly prevalent and it's diagnosed in 15% of adolescents and 50% of adults with CF. It's associated with worsening lung function and nutritional status, but with increased pulmonary exacerbations and mortality. Its onset is often insidious, and this necessitates providing ongoing surveillance for it that's proactive. Current guidelines recommend 2-hour oral glucose tolerance testing, or OGTT, once a year for people with CF over 10 years of age. However, the OGTT screening rates are low every year, at less than 30% in adults and less than 60% of adolescents nationally. Our aims were to conduct a survey of, number one, CF center directors in the US, and number two, endocrinologists affiliated with the Envision program, in order to characterize current CFRD screening practices, have a better understanding of provider perceived barriers to screening, and to identify possible strategies for improving CFRD screening. We developed 2 REDCap surveys, each of which consisted of 23 questions related to CFRD screening practices. Both surveys included questions regarding CF center practice settings and patient population demographics, specific details regarding how OGTTs were ordered, coordinated, and how they were performed, the use of alternative glycemia screening strategies, and provider perceived barriers. In addition, the endocrinologist survey had questions regarding the interpretation and follow-up practice management based on results of the OGTT as well as other measures of glycemia. For the analysis plan, survey responses were summarized using means and standard deviations, or medians and first and third quartiles for continuous variables, and frequencies with percentages for categorical variables. We categorized the CF centers into those that had greater than 50% OGTT completion rates in the preceding year, as well as those that had less than 50%. CF center characteristics and OGTT screening practices were compared using t-tests for continuous or chi-squared tests for categorical variables. We had an 18% survey response rate for CF centers and 63% for endocrinologists. For the characteristics of the CF centers responding, 44% of survey respondents identified themselves as CF center directors, 33% as coordinators, 15% as CF pulmonologists, and 7% as other. 80%, or the vast majority, of CF centers were affiliated with academic institutions. The majority of CF centers responding had somewhere between 25 to 75% of patients with state-funded public health insurance. There is an even distribution of pediatric and adult CF centers, with both being about 40%, and 18% of CF centers had both adult and pediatric patient populations. 92% of the CF centers had an identified endocrinologist, with about half of the centers having an endocrinologist actually embedded within their multidisciplinary center. Regarding the characteristics of endocrinologists who responded to the survey, a little more than half have a pediatric endocrinology background, nearly a third an adult background, and 12% medicine pediatrics. Interestingly, 32% see patients only 18 and above, which corresponds to the percent that have an adult endocrinology background. However, there was a little more overlap between the definition of pediatrics versus med-peds. 20% of endocrinologists see patients from birth to 21 years of age, and this is the more typical pediatric age group, whereas 24% see patients from birth to 25 years of age, and 24% see patients of all different age groups. For the endocrinologist, 20% have patients referred to their endocrine and/or diabetes clinic. 32% see patients within a multidisciplinary CF center, and 40% see patients in both settings. 8% listed other. Similar to the CF centers, an overwhelming majority of endocrinologists are affiliated with an academic institution. Current CFRD screening guidelines recommend obtaining only 0 and 120-minute glucose values. We asked survey respondents what OGTT time points they are actually collecting. 57% of CF centers obtain only the 0 and 120-minute glucose values, whereas 38% also obtain a 60-minute glucose value, and 4% obtain additional glucose values. 20% of endocrinologists only obtain the 0 and 120-minute glucose value, while 72% also obtain a 60-minute glucose value, and 8% reported obtaining additional glucose values. We were interested in determining which characteristics of CF centers correlated with a greater than 50% OGTT completion rate. And 49% of CF centers overall reported a greater than 50% OGTT completion rate in the past year. We hypothesized that having the following variables would be positively correlated with greater than 50% OGTT completion rates. Having less than 50% of patients with state-funded health insurance, having an identified endocrinologist, having a standardized process for ordering and coordinating OGTTs, having an identified role for placing the OGTT orders, or for providing patient instructions for completing the OGTT, performing an OGTT in clinic, and always or almost always providing OGTT reminders. The only finding that was statistically significant was that centers that consistently provide reminders to patients for OGTTs have about a 5 times greater likelihood of having greater than 50% OGTT completion rates. The current guidelines only recommend OGTT screening in healthy outpatients with CF. So we asked survey respondents what alternate glucose strategies that they are using. 64% of CF centers reported also, or in addition, obtaining a hemoglobin A1C level. Nearly 50% obtain a fasting plasma glucose. 30% utilize continuous glucose monitoring, or CGM, and 55% obtain finger stick monitoring for glucose levels. For the endocrinologist, 92% obtain a hemoglobin A1C, 2/3 a fasting plasma glucose measurement, 58% utilize CGM, and half utilize finger stick monitoring. So our conclusions are, although OGTT is considered the gold standard screening method, the completion rates continue to be subpar, and our study shows that practice variation exists, and many providers are utilizing other methods for screening for glucose. Utilizing a consistent reminder system for scheduling OGTTs may help improve completion rates, and we urgently need more studies to improve our approach to CFRD screening. I'd like to thank the CF Foundation, my national mentors for the Envision program, and everyone who helped with this work. And I'm now open for questions. Thank you for your attention.
So just a reminder to everyone to use the app to ask questions. So this question asks, were the reminders from the healthcare team to the patient or reminders to the healthcare team?
It's a great question. Specifically to the patients.
I have a question. Was your survey done during the pandemic years? I just wonder if the results would be different if we repeated it now.
That's a great question as well. Well, I joined the Envision program right before the pandemic. And so, yes, it happened to be during the pandemic years. And no one has actually done this type of a survey in the past, so we don't really have a comparison before the pandemic.
Okay.
I also have a question. So I thought it was interesting how many clinicians were using the 1 hour time point. So is that something that you think, I don't know, from your study, if there are questions around why this is the case, or if this is something that particularly the endocrinologists think we should be incorporating as standard practice?
Yeah, so we didn't specifically ask why it was being included, but whether or not it was being included in what glucose time points. So that was to obtain descriptive statistics just to get an idea and to inform future studies. However, there is literature on indeterminate glycemia, and it's not entirely clear yet when the right time is to intervene with insulin or other ways of managing the glucose. It's also not entirely clear if it helps predict, with the CFRD progression, exactly when that onset might be. Yeah.
And we have another question through the app. So what are the disadvantages of using hemoglobin A1C for screening?
Yeah. So with the hemoglobin A1C, the problem is that it tends to find CFRD later in the course. With CFRD, the issue is more with having delayed insulin secretion and then having a mismatch with that with the carbohydrate load. So if you just obtain a hemoglobin A1C value, then you're going to miss cases. And then also if there's abnormal hemoglobin or other factors that could also limit it. So the OGTT is a better way of having a standardized way of looking at the pancreas being able to handle a glucose load.
And someone asked, they said, sorry if I missed this, do adult and pediatric centers differ in uptake of OGTT?
In uptake?
Yeah, in terms of, yeah.
Yeah, definitely. The pediatric centers, for some reason, do better. I don't know exactly why, if anyone knows. Yeah.
And then someone asked, do you have a sense of how many respondents use A1C only and then progress to OGTT if above a certain threshold?
So we didn't specifically ask who was using hemoglobin A1C only. We just asked what other methods were being used.
Sorry, I'm just bouncing between discussion and questions. So for the future, if you can keep your questions in the questions, it'll just make it easier for us. But you're welcome to use the discussion. I think you can interact in the discussion, perhaps. So one question is, how do we incentivize our patients to do an OGTT?
That is $1 million question. We try. To be honest, as a pediatric endocrinologist, I don't really do OGTTs for type 2 diabetes screening very often because it is really difficult to get it done in the pediatric patient population. So it's interesting that the rates are higher in the pediatric population. And some of the labs also don't know how to do the glucola part and the glucose draws for the younger patients. And if their weight is too low for 75 grams, so that tends to be a problem. So, yeah.
And then there's one more question. How accurate are the finger sticks for diagnosis of CFRD? I don't know if you have an answer to that.
Yeah, not accurate, not recommended. So even for not even just CFRD, but diabetes specifically for screening, you don't make a diagnosis based on a finger stick value. You base it on a laboratory value. There can be some variation up to like 10 to 20% between the lab versus the finger stick glucose values. And again, doing the OGTT is a much more standardized way because you have a set glucose load. You don't have other meal sources mixed in together with that. You fast for 8 hours. You have to eat enough carbohydrates ahead of time. So that's a very different way of screening for it than just sending someone home with a meter and having them check. And then sometimes if they don't clean their hands all the way or they dilute too much, there's a lot of different ways that it can affect the value.
Great. Thank you very much.
Thanks.
So our second speaker on the program actually is unable to make it. We found out just about half an hour before the session. He missed his connecting flight. So our second speaker was supposed to be Dr. Remy Rabasa-Lhoret from Montreal. And he was actually going to present a first glance at the new Canadian CF-related diabetes guidelines. And these are something that were identified as a need because the current diabetes guidelines that exist through the CF Foundation, as mentioned by Stacey, are very outdated, 2010. So a group of Canadian clinicians came together and have been working on these guidelines over the last year or so. So I'm familiar with the guidelines because I'm involved with the group. It was all very preliminary new information because nothing has been released yet, but they hope to be published in early 2023. So unfortunately, he won't be speaking today, but stay tuned for that. And in my highlight slide at the end, I do, just because I only found out he wasn't coming about half hour before the presentation, I do have a couple of hints as to what some of the key recommendations are that I think everyone will find really interesting.
So that's motivation to stay till the end. All right, our next speaker is Alexis Hugendorn. Alexis is a registered pediatric nurse at Ann and Robert H. Lurie Children's Hospital in Chicago. She's worked with the pulmonary and CF population for over 3 years and is currently a doctoral pediatric nurse practitioner candidate at Rush Memorial University, focusing on children with chronic illness. Alexis will be presenting on the implementation of a tiered system of screening for CFRD using both OGTT and continuous glucose monitoring.
Thank you, Stacey and Lisa, and thank you everybody for having me. Throughout my presentation, there will be no relevant disclosures to disclose, I think. Just for the first one. Okay. About 6 months into my current role at Lurie CF Center, we began to notice a downward trend in CF-related diabetes screening, which brought us to think more deeply about the topic at hand today. My presentation will dive into how and why we implemented a tiered system of screening for CFRD using both oral glucose tolerance testing and continuous glucose monitoring. In 2020, national CFRD screening rates took a major hit for obvious reasons and haven't quite returned to pre-pandemic levels yet. You can see that in the top graph. According to the CF Foundation Patient Registry, Lurie Children's Hospital screened 60.9% of non-diabetic patients over 9 years old in fiscal year 21 using an oral glucose tolerance test. This was right around the median of CF pediatric programs around the United States. In fact, nationally, only 59% of adolescents and 25% of adults were screened using an oral glucose tolerance test in FY21, even though it's estimated that CFRD develops in upwards of 20% of adolescents and 40 to 50% of adults. We know that left untreated, CFRD can cause a myriad of issues related to decline in lung function, decline in nutritional status and weight loss, and fatigue. The Journal of Cystic Fibrosis published a study in 2020 showing that patients seen at centers that screen more aggressively for CFRD have less decline in health prior to a diagnosis. It's our job as practitioners to care deeply about adequately screening patients to catch CFRD before it plays a major role in the overall health of our patients. At Lurie, we'd been using the same process for screening since around 2010 when the CF guidelines were published. Screening included a 2-part oral glucose tolerance test with a fasting and 2-hour postprandial result. If both tests resulted normal, we would just recheck after 1 year. However, if either the fasting or 2-hour postprandial result was elevated, we would schedule a time for the patient to meet with a certified diabetes educator and learn how to monitor blood glucose using an at-home glucometer. There are many problems with this process, however. First, we had limited access to those certified diabetes educators, which would often delay needed care for CF patients that would eventually be diagnosed with CFRD. Also, patients would have a hard time adhering to the self-monitoring recommendations given by their CDEs, especially for our kiddos at Lurie. It was really hard for them and their parents to have to poke them every time they wanted to get their blood sugar checked. Depending on the blood sugar recordings produced, results would be sent to their primary pulmonary team, who would then refer patients with abnormal blood glucose self-monitoring results to the endocrine colleagues. However, most often, the data that we sent over wasn't even sufficient to accurately prioritize routine versus urgent referrals. Like we've mentioned a couple of times now, the guidelines related to CFRD screening were published in 2010. They haven't been updated since the introduction of highly effective modulators like Trikafta, or with the evolution of technology that we have for screening today. Additionally, solely using an OGTT may no longer tell us enough. It doesn't give or reflect accurate day-to-day glycemic patterns, and leaves the severity of illness open to interpretation when the results aren't grossly abnormal. We found that because of the limited access to pediatric endocrine services, particularly related to the increase in type 1 diabetes related to the COVID-19 pandemic, endocrine providers were less motivated to see our patients if their OGT was borderline abnormal. And sometimes these first available appointments that our patients were getting were 3 to 6 months out. Our endocrine providers began asking for more information to provide an accurate referral length. As the first step in refining our screening protocol, we created some educational handouts for patients to learn why an OGTT was important in the first place. We wanted to implement some health promotion strategies and just the awareness of CFRD in general before it's ever a reality for our patients. After education, we still give a yearly oral glucose tolerance test. However, we now give patients a 3-part test with that fasting, 1 hour postprandial, and 2 hour postprandial result. This change came through a collaboration with our endocrine team and finding literature that suggests that that 1 hour result is a lot more sensitive in catching a CFRD diagnosis. If any of the 3 results came back as abnormal, we now offer our patients a 10-day continuous glucose monitoring. We specifically partnered with Dexcom. Initially, we were given courtesy Dexcom 10-day starter kits. However, currently, Lurie CF Center has grant funding to replenish that supply. We acknowledge that this may be a potential barrier to using continuous glucose monitoring long-term, as our endocrine colleagues say that it's really hard to get that insurance approval for patients who aren't already on insulin therapy. Some patients chose to forego that continuous monitoring, but we specifically encouraged patients with any declining lung function, unexplained weight loss, or grossly abnormal OGTT results to use that continuous monitoring. If a patient did choose to use a Dexcom, we would set them up with a nurse-only visit where the monitor itself would be placed and some education would be provided on what to expect in that 10-day period where they'd be wearing the Dexcom. After 10 days, the data and trends would be analyzed and jointly reviewed by the primary pulmonary teams and the endocrine team to establish the need for endocrine involvement and the urgency of an endocrine appointment. Now in FY22, Lurie Children's Hospital supported 93 CF patients over 9 years old. 11 of those patients had a known diabetes diagnosis, either CFRD or type 1. This left 82 eligible patients to receive yearly CFRD screening through our new process. Over the year, 16 of our patients refused screening or had an OGTT order placed but didn't go to the lab to get their blood drawn. We ended up giving a total of 66 patients an initial OGTT. This meant that we accomplished a screening rate of 80% of eligible patients, which was up 20% from our fiscal year 21 numbers. Now, pointing you to the graph on your left, around half of screened patients had abnormal OGTTs in fiscal year 21. 23% of the patients we screened had results that showed impaired glucose tolerance. This meant that their fasting blood glucose was between 100 and 126 milligrams per deciliter, or their 2 hour postprandial result was between 140 and 200. 7% of the patients that we screened had results that were diagnostic of CFRD. This meant that either their fasting glucose was above 126 or their 2-hour postprandial was above 200. Lastly, 20% of the patients we screened had a result of indeterminate glycemia. This was a normal fasting blood glucose and a normal 2-hour rate, but an abnormal 1-hour postprandial result above 155. This was a new diagnosis for our CF center with the addition of that 1-hour postprandial result. There are several thresholds in the literature between 155 and 175 for what should be considered an abnormal 1-hour postprandial result. We chose 155 as a way to be a little bit more aggressive in our screening strategy. We decided this in partnership with our endocrine colleagues to provide the greatest sensitivity to our testing. Throughout FY22, we set up 15 patients with the Dexcom monitors. One of those patients, we'll call her Josie. Josie is a 10-year-old Hispanic female who is not eligible for highly effective modulator therapy, and she's pancreatic insufficient. She presented as a healthy girl with rare exacerbations. She was moderately overweight at the time of screening and had no recent weight loss. Her OGTT resulted at a fasting rate of 87, and her 2-hour postprandial result was 151. Now, prior to our new screening protocol, we would have just diagnosed her with impaired glucose tolerance after a borderline abnormal test. We would have then relied on home glucometer readings or given her a first available endocrine appointment, which again, like I said, was sometimes looking 3 to 4 months out. However, with our new screening method, we knew that her 1 hour was also extremely elevated at 223. We set her up with a Dexcom and were able to then see her average blood glucose and day-to-day glycemic patterns plotted over a week period. On the left, you can see that her average blood glucose over that 10-day period was actually 192 milligrams per deciliter, and her blood glucose would spike upwards of 400. This additional information was discussed with her primary pulmonary team and Lurie's endocrine team. She was then given a 1 to 2 week urgent referral for endocrine and was started on Lantus and Humalog daily after that initial visit. Her CFRD easily could have been missed if it wasn't for our new screening protocols. In fact, she wasn't the only patient with a similar situation. One of our patients was found to have indeterminate glycemia after this new oral glucose tolerance test, and he also had a Dexcom and was found to have an average blood glucose of 142. He was scheduled for an endocrine appointment within 2 weeks as well, and subsequently diagnosed with CFRD. These patients neither of them were considered high risk for CFRD, but were diagnosed promptly because we implemented these aggressive screening patterns. For some patients and families, the continuous monitor was able to reassure them that the patient's day-to-day glycemic patterns were in normal range and that testing yearly is an appropriate course of action. Especially for parents, it gave peace of mind that we were doing all we could to get the most accurate data about their child's blood glucose. Most importantly, maybe for our study, CGM allowed the pulmonary and endocrine teams to support the prioritization of urgent versus routine endocrine referrals with a complete set of data. Patients who needed to be seen quickly were seen in an appropriately timed fashion. Another interesting outcome from our study came from when we compared patients on highly effective modulator therapy to those who were not. You can see from the bar graph on the left that individuals on modulators were slightly more likely to undergo testing. However, the bar graph on the right shows that of those tested, patients who were not on highly effective modulator therapy were more likely to have an abnormal OGTT. This may suggest that we need to work harder as an institution to ensure that patients who are not on modulator therapy really follow up and be screened for CFRD with an OGTT. On the other hand, 46% of the patients who were on highly effective modulator therapy and screened for CFRD had an abnormal OGTT, and 75% of our new CFRD diagnoses in FY22 were patients on modulators. While the introduction of highly effective modulators in recent years clearly improves CF health outcomes, it should not negate the fact that we need to screen for CFRD in all patients. All patients over 9 should continue to be screened whether on HEM or not. Now, at Lurie, we still have a ways to go in mastering our new 2-tiered screening protocol. We're still working on increasing the number of OGTTs we give and the compliance for those tests, and making continuous glucose monitoring readily available to get the most accurate referral times for our endocrine team. However, we learned many different lessons that we hope you can take to your practices all over the world. First, our data show that a traditional 2-part OGTT may miss a CFRD diagnosis. Implementation of that 1-hour postprandial result can catch indeterminate glycemia and can give greater insight into who needs to be followed more closely. Also, we can learn a lot about a patient's day-to-day glycemic patterns through continuous monitoring results, and the results are extremely useful and welcomed by our endocrine colleagues. It makes the initial consultation happen efficiently, and it also just makes that initial visit more productive as well. Patients were also really receptive to trying the continuous glucose monitoring overall and had a good experience with it. One of our young adults even sent a MyChart message saying it was super cool seeing what her blood sugars were doing all the time, which for those of you who work with young adults, you know that getting them to use MyChart in general is a feat. So this was a good comment. Finally, our study suggests that we can't always rely on these traditional clinical warning signs of CFRD to prompt screening. We have to be proactive at catching CFRD before those warning signs turn into major effects on the overall health of our patients. At the end of the day, if proper screening techniques are important to us, they will be important to our patients too. So for patients like Josie, please consider reviewing your screening protocols and catching CFRD before it's too late. Thanks so much.
Great job. Okay, the questions are flooding in. Interesting. Does your clinic perform, they're flipping through here, so, okay. Let's start at the beginning. How will you sustain continuous glucose monitor use outside of your grant?
I think that's kind of one of our biggest questions moving forward. We don't know exactly how long the grant will last, and I think we're going to start trying to look into maybe even some different brands to see if there's cheaper options for our patients. I spoke with somebody, I don't know if she's in the audience, but she used the Libra system, and there's, quite a few different types of screening techniques that we could use for that continuous glucose monitoring.
Okay. Was there any relationship between A1C and continuous glucose monitor results in your clinic?
Like Dr. Hicks said, I'm not an expert, so I don't know for sure, but I think the hemoglobin A1C results are kind of come later down the road, so I think we want to use that continuous glucose monitoring for more early detection. I think it'd be really interesting to look and see how the two really relate to each other, but I think using it for more early detection, especially for pediatric patients, is really helpful.
Whoa, okay.
You're scaring me, Stacey.
No. Can you clarify what you considered normal and abnormal results on continuous glucose monitoring?
Yeah, I think it was over 140 was if it was an average blood glucose of over 140, we would consider that abnormal. And Stacey, you might be able to add something too.
Well, we did send the continuous glucose monitoring results for the 10-day period in an EPIC encounter to the endocrine provider to review for their feedback. And they sort of set the threshold for us that in someone that has an average blood glucose under 150, they don't look at it as urgently, although they did look at all the trends each day. So we didn't have a set definition for abnormal or normal on continuous glucose monitoring, and I don't really think there is one. I think it's looking at trends over time. But, you see more questions? Our iPad's being really finicky. And losing its juice. Someone asked if we perform our spirometry before our continuous glucose monitoring, before our OGTTs.
Oh, sorry, at the time. We like to have them come in for OGTTs before glucola. I've personally never tried it, but I've heard it's really gross and makes kids nauseous. So a lot of times we try to get their fasting level and have them drink the glucola before they get their spirometry.
There's a question here asking if you have any thoughts on using mixed meal tolerance tests as an alternate test from the OGTT.
I just realized I totally switched around for that last one. We get the spirometry before the glucola because it makes them nauseous. Sorry about that. Can you repeat that one more time?
Yes. Actually, I'm going to ask you a different question first, and then I'm going to jump back to that one. One of the questions was, did you also obtain an A1C at the same time of OGTT? And was it abnormal in Josie's case?
Often we did not always get that hemoglobin A1C at the same time. Josie's sister actually did have type 1 diabetes, so for her, we did get the hemoglobin A1C, and I'm forgetting the exact number right now, but it was normal, which kind of helped show that it was CFRD and not type 1 diabetes.
How did you increase the OGTT screening completion rate by 20% in a year?
Ooh, it was really these three ladies in front. It took a lot of work. I think one thing that we noticed in our center as well was reminding patients in an EPIC message, just reminding them to come with that fasting level. It took a lot of work. Just sometimes I would walk patients to the lab. And yeah, it just kind of took a lot of hard work. But yeah, it was fun to see that it actually worked.
Okay. Someone asked if continuous glucose monitors can be sterilized and reused.
So each one is a little bit different. The Dexcom has a receiver that can be reused over and over, but the actual transmitter that is attached to the piece that's in their arm or their stomach is thrown away after a 10-day period. So it's kind of not a clear answer, and every different continuous monitor is a little bit different.
Okay. Two questions about continuing the use of continuous glucose monitoring in these patients after the 10-day period.
There were a couple patients that we ended up doing 2 sets of the 10-day Dexcom monitoring for, but I think often we would kind of get those initial results, get them an initial visit with our endocrine team if they needed to, and then endocrine would kind of go from there and see what they needed kind of going forward. And obviously our pulmonary team would follow up with them and work together with endocrine going forward, but I think that was more so on our endocrine teams, on their decision track, so.
All right. And then a question, are you concerned about over-diagnosing patients because there are, I think, no data, or there are data showing a proportion of patients with impaired glucose tolerance or indeterminate glucose may revert to normal in following years?
I think it's definitely something we obviously don't, in our endocrine team, doesn't start insulin right away on every patient that has impaired glucose tolerance. So I think we're just looking to get an earlier and a better, clearer picture about what their blood sugars are doing on a day-to-day basis. I don't think it means jump to insulin right away, jump to therapy, but I think it's just a better way to know kind of what to expect in the future for some patients and just have better insight on how they're doing at that time.
There's lots more questions, but we're going to stop grilling you. So if you want to answer any in the discussion, you're welcome to.
Perfect.
Thank you very much.
Thank you, guys.
So our next speaker is Andrea Lorenz. She's a third-year medical student at the University of Colorado School of Medicine. And as a native of Denver, she's excited to be attending medical school in Colorado, where she skis, hikes, and plays tennis in her time away from school. She's a graduate of the University of Pennsylvania, so she's very grateful for the opportunity to be back in Philadelphia for NACFC. So today she'll be presenting on using CGM to predict disease progression and the development of diabetes in youth with CF.
Thank you for the opportunity to speak today. And before beginning, I wanted to take a moment to thank my mentor, Dr. Christine Chan, and colleagues from the University of Colorado and Children's Hospital, Colorado. Perfect, thank you. Just of note, this study was supported by various grants, including 2 grants from the CF Foundation. As we've discussed, CFRD is an incredibly common complication of CF, affecting up to 20% of youth and 30 to 50% of adults. Our group has previously published a retrospective study looking at the relationship between dysglycemia as measured by CGM and pulmonary function over the preceding year. This study had a couple of important findings. First, it demonstrated that using CGM, we can detect early glucose abnormalities before either prediabetes or CFRD are apparent on an oral glucose tolerance test. In addition, the study showed that greater dysglycemia as measured on CGM, was correlated with a greater rate of change in pulmonary function over the preceding year. While various retrospective studies like this exist, few studies have addressed the ability of CGM to predict prospective clinical outcomes in CF. Therefore, the aim of our analysis was to determine whether we could use CGM to predict both 1- and 3-year prospective clinical outcomes in youth with CF who do not have a prior history of CFRD. The 3 clinical outcomes that we were interested in studying were the trajectories of the body mass index Z-score over time, the trajectories of the pulmonary function tests over time, and the time to diagnosis of CFRD. Our study was designed as a prospective analysis at a single CF center out of Children's Hospital, Colorado. The CGM data was collected between 2014 and 2018 as part of the Glycemic Monitoring in CF study, which is also known as the GEM-CF study. To be included in the study, participants had to be between the ages of 6 and 25 years old and have received a diagnosis of CF via newborn screen, sweat chloride testing, or genetic testing. Those who had a history of type 1 or type 2 diabetes, hospitalization in the prior 6 weeks, or pregnancy were excluded from the study. We also excluded individuals who had used medications that could alter their glucose levels at the time of CGM wear. This included individuals who had been on insulin therapy or systemic steroids. For our statistical analysis, we looked at the associations between the baseline CGM variables and trajectories of BMI Z-score and PFTs using mixed effect models. The PFT variables that we were interested in were the percent predicted FEV1 and the percent predicted FVC. We then looked at the associations between CGM variables and time to CFRD using Cox proportional hazard models. Here we illustrate how individuals were recruited for our study. We started with 101 youth with CF who were enrolled in the GEM-CF study. These are individuals who were patients at our diabetes and pulmonary clinics. Of these individuals, 4 had incomplete CGM data, One individual had a diagnosis of CFTR-related metabolic syndrome, one did not return the glucometer for CGM calibration, and two were diagnosed with pulmonary exacerbations and started on steroids shortly after CGM placement. Therefore, these individuals were excluded, and we were left with the remaining 93 youth with CF. After we excluded the 18 participants with CFRD on known insulin therapy, we were left with 75 youth who were included in our final analysis. This table summarizes our cohort of 75 individuals. They are patients who were a mean of 13.4 years old at baseline, and 56% were female. Looking by race and ethnicity, 87% were white, 11% Hispanic, and 1% Black. 93% of them were pancreatic insufficient, and this was a relatively healthy group. They had a mean BMI Z-score of negative 0.04. Looking at their pulmonary function, they had relatively good lung function with a percent predicted FEV1 of 96% and a percent predicted FVC of 103%. From a glycemic standpoint, we chose a few select variables that would capture the average glucose, the percent time in hyperglycemia, and the glycemic variability. Participants had a mean A1C of 5.6%, which is in the normal range, and an average sensor glucose of 112 on CGM, with only 13% time spent over 140 and 1% time spent over 200. Two measures of glycemic variability that we looked at were the coefficient of variation and the mean amplitude of glycemic excursion, or the MAGE. For those who are not as familiar, the coefficient of variation is a measure of the dispersion of the data around the mean, and the MAGE captures the excursions that exceed one standard deviation from the mean. These values were both higher than what we had previously found in a group of healthy controls. So here the coefficient of variation was 20% versus 13% in healthy controls, and the MAGE was 79 milligrams per deciliter versus 62 in healthy controls. We followed individuals in the cohort for a mean of 3.6 years, and over this period of time, 9 participants, or 12%, developed CFRD. And we defined a diagnosis of CFRD by an OGTT with a 2-hour value over 200. This is a figure of the trends in the BMI Z-score over the 3-year period of study, where the blue line demonstrates a smooth mean at each time point. As you can see, in this relatively healthy cohort of adolescents, the BMI Z-score was relatively constant over the 3-year study period. Similarly, this is a chart of the percent predicted FEV1, which was also pretty constant after an initial decline, emphasizing just how healthy this group is. And this table really summarizes the core of our analysis, which shows the predictive value of the CGM variables for 3-year clinical outcomes. While we summarize the 3-year outcomes in this table, we did look at both 1- and 3-year outcomes, and we did not see a difference in the results at these 2 time points. So to walk you through the table, in the first column are the CGM variables that we measured at baseline. These are the average sensor glucose, the percent time over 140, percent time over 200, coefficient of variation, and the MAGE. If we focus on columns 2 through 4, we see that these baseline CGM variables did not predict BMI or pulmonary decline as measured by the BMI Z-score, the percent predicted FEV1, and the percent predicted FVC. We did, however, find that for every 5-unit increase in the average sensor glucose and percent time spent greater than 140, there was about a 22 to 23% increased risk for the development of CFRD. So in conclusion, in our group of healthy youth with CF without a prior diagnosis of CFRD, the CGM variables that we explored were not predictive of prospective clinical decline as measured by the change in BMI and lung function. As we discussed, there were select CGM variables, in particular the mean glucose and the percent time spent greater than 140, that did predict an increased likelihood of developing CFRD over the 3-year period of study. Looking forward, we hope that studies will continue to explore whether we can use CGM to predict which individuals are at greatest risk of glucose-mediated clinical decline. And in particular, we identified 2 areas of focus for future studies. First, we need larger prospective studies that include adults to determine the predictive value of CGM across different age ranges. This is really of particular importance in our new era of highly effective modulator therapies, as patients are living longer lives with early dysglycemia. Thank you.
Thank you for the talk. I have a question. I was surprised that you didn't find a relationship in values above 200. Is that just because this number was so small, or do you have any thoughts on that?
Yeah, I think what we found was that the percent or the amount of time spent over 200 in this group was only 1%, and so the event rate was pretty low, which is why I think we didn't see significance in that particular result.
In the 9 patients in the study who developed CFRD over 3 years, was there any decline in FEV1 or BMI compared to the patients who did not develop CFRD? Did you look at that?
We haven't looked at that yet, specifically broken those individuals out, but we're planning to highlight that for the future before we work further with this data.
There's a question, I think this one was for you. Is there a certain percent of time above 140? Oh, I just lost the question. That you would suggest as a cutoff, or is more data needed to determine this?
So we didn't look at this with this particular analysis, but I think we have previously looked at whether there's a certain cutoff that would be sensitive or specific to help us answer this question, and I don't think that we've found any cutoff in the past that has had good sensitivity and correlated well with a 2-hour OGTT, so I think we still need a lot more studies around that to really answer that question.
And then one more question. Did you look at hypoglycemia and the risk of progression?
No, we haven't looked at that this either.
Okay, if there's no more questions, I think we'll go on to the next. Oh, yes, please.
One more question. So could the CFRD have been diagnosed in those 9 patients just by the CGM without using
I have to go back and look at the actual CGM tracing, but in this case, they were definitely diagnosed with the OGTT itself, since I think there's not a particular cutoff on CGM that we've identified to be able to diagnose CFRD.
And I'll just add a comment to that. I don't think there are set parameters on what a diagnosis would be based on using continuous glucose monitoring, because the definition's built around a glucose load of 75 grams and your subsequent values. So I don't know if having a certain amount of time over 200 would give you a diagnosis. There's just not real clear guidelines that I'm aware of.
And just to clarify, so these data were prospective, and just the baseline CGM data was on people's diabetes and over the years when CFRD.
We have a comment in addition.
So just to address some of the questions people keep bringing up, there's a difference between screening and diagnosis, and as of right now, the only thing that predicts outcomes in cystic fibrosis based on data is OGTT. So for right now, we don't have any cutoffs, although Dr. Chan's working at it really hard for CGM that are predictive of outcomes. So as of right now, although too bad heard me back here talk about the guidelines, but as of right now, yeah, you have to use ADA approved criteria for diagnosis.
Did everyone hear that? Yes? Oh, no. Okay, so the only established criteria for making a diagnosis of CFRD is the OGTT, although more to come as the new guidelines come out.
Okay, so our final speaker for this afternoon is Dr. Melissa Putman, who is actually coming in to speak for Dr. Jordan Sherwood, who was unable to make it today. Sorry, I have your bio here.
Sorry.
Sorry, lots of last-minute changes, so the bio's here. So Dr. Putman is a CF endocrinologist for the Massachusetts General Hospital Adult CF Program and the Boston's Children's Hospital, Brigham and Women's Hospital CF Center. Hopefully that's correct. Sorry if I butchered it. She is board certified in internal medicine, pediatrics, adult endocrinology, and pediatric endocrinology. Her primary research goal is improving the care of children and young adults with chronic diseases to prevent the endocrine complications that may significantly affect their future adult lives. So today she'll be presenting on behalf of Dr. Jordan Sherwood on automated insulin delivery with the iLet bionic pancreas for the management of CFRD.
So Jordan was so sad that he couldn't be here to present these results because he worked really hard on this study with all of us. But he has a baby on the way who is determined to come into the world a little early, and so he needs to be at home. And so I'm happy to give the talk in his place. Everyone
For
has
the
trouble
first slide,
advancing.
you have to click there.
Oh, I see. There we go. There we go. All right, here are our disclosures. All right, so I think everyone here can appreciate that the reason we care about diabetes in people with CF is that we know that the development of CFRD is associated with all the bad things that can happen in CF, so compromised pulmonary function, decline in BMI, and even earlier mortality. And so the primary goals when we think about treating CFRD is the preservation of pulmonary function and maintaining nutritional status. Although I would argue that with the onset of Trikafta, we also are going to have to start thinking a lot more about microvascular complications and other outcomes too. So right now, insulin is the only recommended therapy for CFRD because really this is the only treatment that has been shown to improve BMI, to be associated with improvements in pulmonary function, and indirectly may improve mortality. But insulin therapy is hard, and a lot of our patients with CFRD really face a lot of very unique challenges in managing their diabetes. So for one, they often spend a lot of time taking care of their pulmonary disease. So when we add insulin checks, insulin injections, and finger stick checks, and carbohydrate counting to that, it can be really overwhelming. In addition, a lot of our patients require a high-calorie diet in order to meet their nutritional needs. And often that means high carbohydrates to get those calories in, and that can be challenging for insulin to control. In addition, a lot of patients require G2 feeds also, which is a very big carbohydrate load that can be difficult to control with injections. In addition, patients often have fluctuating insulin requirements, and I feel like I see this more in my patients with CFRD than those with type 1 diabetes, where when they're sick or when they need steroids, they'll have a lot more insulin resistance and need more insulin, but then when they're healthy, their needs will decrease. And then lastly, a lot of people with CF, even without CFRD, are at risk for spontaneous hypoglycemia. So it can be hard to treat a patient with insulin, which causes And so the idea behind artificial pancreas systems is that we're trying to close the loop. We're trying to use technology to automate insulin delivery to kind of offload the burden and the tasks that people have to do while at the same time improving glycemic control. And so these devices consist of a continuous glucose monitor, which we talked a lot about already. And this continuous glucose monitor is feeding glucose data every 5 minutes to an insulin pump. And this pump has a control algorithm on it that then provides guidance in insulin delivery so that it's changing the insulin that the patients are getting continuously. And this cycle is happening over and over. So we know from people with type 1 diabetes that the currently available automated insulin delivery systems have been associated with a lower A1C, with higher time in target range between 70 and 180 milligrams per deciliter, and have been associated with stable and sometimes even lower rates of hypoglycemia. And this is in type 1 diabetes. But there's still a lot of input that's required, both from the provider and the patient, to work these devices. So for one, the provider, which is usually an endocrinologist, has to put in the insulin settings, so the basal rates that the system is going to use to base kind of a lot of the changes on, the bolus ratios, so how much insulin will a patient get when they put in their carbohydrates, and if they're high, how much insulin the device will give. In addition, patients are still required to count carbohydrates. So they look at their food and decide how many grams of carbohydrates and then enter that into the device. And if the blood sugar is really high, then the patient needs to tell a device to give additional insulin or a correction bolus to bring the blood sugar down. So the device that we have been studying is called the iLet Bionic Pancreas. And this is it's an investigational device at this point, and it's a little different than the other devices that are currently on the market. So for one, this requires only the patient's weight to initialize the system. So there's no putting in any kind of settings or carb ratios or anything. And the operation is based only on CGM glucose input. And in the first 24 to 48 hours of using the device, the system will adapt. It'll learn how much insulin that patient needs, and then it'll continuously change over time. So if those needs change, then the device will keep track of those changes. The other difference is that there's no carbohydrate counting required. So for this system, people can use what we call qualitative meal announcements. So this meal is typical for me, more than typical or less than typical, and the device will learn what that means and then administer the insulin accordingly. And so this device has been studied in type 1 diabetes, and this is the results of the pivotal trial that was just published last month in the New England Journal of Medicine. So for this trial, this was a 13-week, multi-center, randomized clinical trial in 219 adults and children and adolescents, ages 6 years and older, who had type 1 diabetes. They randomized participants 2-to-1 to either the insulin-only bionic pancreas or to standard of care. And the standard of care was basically broken down 30% on multiple daily injections, 30% on an insulin pump without automation, and then 30%-ish around in patients who are already using a currently approved FDA automated insulin device. The primary outcome was the change in A1C from baseline to 13 weeks, comparing the two groups. And as you can see here, I'm showing you the percent change from baseline in the hemoglobin A1C on the y-axis, and then the x-axis is the baseline hemoglobin A1C level. The blue dots are the standard care, and that actually they didn't really change very much. But the orange dots are the patients who use the bionic pancreas. And so you can see that there is actually a greater decrease in A1C with the use of the bionic pancreas. And overall, there was a 0.5% decrease in A1C and bionic pancreas compared to standard of care. And that number is important because that's what the FDA considers to be clinically significant in device trials. I'll also point out, if you look at the orange lines toward the bottom, let me use this picture over here, those patients who had the highest A1C to start tended to have the greatest change in A1C and benefited the most from the device. Other outcomes on this trial are shown here. There was a 16-point decrease in average glucose with the bionic pancreas. Patients spent 11% more time in their target range. There was also less time spent in hyperglycemic ranges without any changes in hypoglycemia. So we looked at this device in 3 adults with CFRD in a pilot study that we published a few years ago. And so just to walk you through this slide, each of these lines represent the mean glucose on CGM for each of the 3 participants. The circles, the size of the circles represent how much hypoglycemia they're having. So bigger circle, more hypoglycemia, smaller circle, less hypoglycemia. And here, the white here are the patients on their usual care, what they usually do to manage their diabetes. This blue area here is the average glucose on the insulin-only bionic pancreas. And so you can see it's nominal because there's only 3 people, but there's a trend toward improvement in their average glucose with the insulin-only device. Here in the green is the bihormonal system. So this device can also be used with insulin and glucagon together. So you give insulin when the blood sugar is high, give glucagon when it's low. And so there was even further improvement with the bihormonal device. And so we used this pilot data to get funding from the NIH to do a bigger study. And I'm really excited today to tell you about the results of that study. So this was a randomized crossover trial where we took 20 adults with CFRD and randomized them to either 2 weeks of the bionic pancreas or 2 weeks of usual care. And then after that initial period, they switched to the other arm. The study population, so it was all adults over age 18. They were on insulin therapy, at least 0.1 units per kilo per day. They had to have stable modulator therapy and stable insulin modality for the preceding 4 weeks. And they also had to have no pulmonary exacerbations or IV antibiotics in the past 4 weeks. And in the bionic pancreas arm, patients were initialized on the device with just their body mass, just like the pivotal trial in type 1 diabetes. The algorithm was the same as for those for type 1 diabetes, and there were no limitations on work, diet, or exercise during both arms of the study. Our primary outcome was percent time in target range, 70 to 180 milligrams per deciliter, which is a pretty standard outcome for device trials. Our other outcomes included mean CGM glucose level, time spent in hyperglycemic ranges and in hypoglycemic ranges, glycemic variability, patient-reported outcomes, and safety outcomes. And I'm really excited to tell you about our results. So of the 20 participants in the trial, the mean age was 40. There were 50% female. Their A1C at screening at baseline was 7.4%. And for those who were already using CGM at the time of screening, their mean CGM glucose was 167. Their total daily dose of insulin was about 0.5 units per kilo per day. And on average, they had had CFRD for about 15 years. In terms of their usual diabetes care, 90% of them were using continuous glucose monitors. 50% were on multiple daily injections, and the other 50% were on insulin pumps. Of those patients on pumps, 8 of them were already using a hybrid closed-loop device that's currently FDA approved, and then the other 2 were using a pump without automation. They had moderate lung disease with an FEV1 of about 70%. All of them were pancreatic insufficient, and 85% were using CFTR modulators. And here is the result of our primary outcome, percent time in target range. So again, to walk you through this slide, each line here represents a participant in the trial And I'm showing you their percentage of time in target range. The white is on usual care and the blue is on the bionic pancreas. And again, the size of the circles represents how much hypoglycemia they're having. So bigger circle, more hypoglycemia. And what you can see, this red line is the mean for the entire group. And we saw an increase in the percent time in target range from 63% on usual care to 75% with the bionic pancreas. And that's also important because this dotted line right here is 70%. That's our goal. We're trying to get patients to get to 70% time in target range. There was no significant difference in time spent in hypoglycemic ranges. And these are some of our other secondary glycemic outcomes. So mean CGM glucose was lower at 150 with the bionic pancreas compared to 171 during usual care. Again, the percent time in hypoglycemic ranges did not change during the study. It was actually pretty low throughout. But percent time in hyperglycemic ranges decreased with the bionic pancreas. Standard deviation was a little bit lower with the bionic pancreas, but coefficient of variation was not different. And this is an example of the glycemic control with the device over the course of the day and night. So to orient you to this x-axis here is time. So we're looking at midnight to midnight. And all of the CGM data for all the participants are on this slide averaged together. The red line here is the average glucose for the participants while they were on usual care. The red dotted line is the interquartile range. You can see the bionic pancreas here in blue, that the mean glucose for while on the bionic pancreas was lower throughout the day and the night with the device. And you can also see that the interquartile range is a lot tighter. In terms of our safety and adverse events, this was roughly similar between the two groups. I will point out there were more episodes of hyperglycemia without ketosis in the bionic pancreas arm, and this was because they had to call us if that happened and let us know that it was going on while they were on the device, but they did not have to do that when they were on usual care. And so we did collect more of that data in the bionic pancreas arm than usual care. Our key safety outcomes were severe hypoglycemia and diabetic ketoacidosis, and we had 0 events for that in either arm. All right, so to conclude, automated insulin delivery systems for the management of type 1 diabetes, we know have been associated with improvement in CGM metrics and A1C. In this study, in adults with CFRD, automated insulin delivery with the bionic pancreas significantly improved time in target range and decreased time in hyperglycemic ranges without affecting rates of hypoglycemia, which remained low throughout the study. And the interesting thing is just how similar these results were to what we saw in the type 1 diabetes population. And so I think that this study really provides very strong support that we need larger and longer studies of automated insulin delivery systems to really understand the safety, the efficacy, the utility of this technology in this patient population. So I want to just take a second to throw up this acknowledgement slide because I think everyone can appreciate it takes a village to do studies like this, and I am so incredibly fortunate to have a really wonderful and supportive village that's been helping me at the MGH Diabetes Research Center, at the MGH and the BCH, BWH, CF centers. None of this would have been possible without their support. Thank you.
Thank you very much. It's very exciting. I have a question, and you probably can't answer this. How far away is this technology from being accessible, even to people with type 1 diabetes?
Yes, such a great question. So right now, with the data that I showed you in type 1 diabetes, they're actually going to the FDA to work on approval of the device. So it's hard to know exactly how long that's going to take. Maybe a year or so it'll be around that, but it is underway.
Okay, great. The app is not so user-friendly on the iPad, so I don't know if there's any here. Maybe we'll just wait a couple minutes.
I have a comment and a question. First of all, I would say that the average age of your participants was 40, which I think is just exciting to acknowledge. But my question is, with the FDA approval of this for type 1 diabetes, will we be able to add on for
feel like
CFRD? I know that's a loaded question.
I feel like I
but-
planted that question. I
Right.
love that question. So I don't know about you, but I do have trouble getting devices, technology for patients with CFRD because they don't have that E10.9 diagnosis code. And so our next steps for moving forward with further studies is we have funding from the NIH and from the CF Foundation to do a much larger multi-center trial. And the point of that will be to see if we can actually provide enough data to the FDA to get FDA approval of this device for CFRD.
Okay.
So I am very hopeful that the answer is yes.
Okay, so we do have more questions. So one question, were the CGM changes mainly due to those starting the bionic pancreas from MDI compared to those starting who were on an insulin pump?
Yeah, so that's a great question. Those patients who went from MDI to the device did have more significant changes. They also tended to be the ones that started off with worse glycemic control too. And so when you look at those who are already on an automated insulin delivery system, and most of them were on Control-IQ, they definitely had less improvement because they were already doing pretty well.
Another question here, do you think that other modes of diabetes treatment will eventually become obsolete, or is there some benefit to those treatments for certain groups of patients?
Oh my gosh, that's such a great question. So I have seen there's such variability with CFRD. So some people need like just a little bit of insulin with meals, and that's it. And they're not going to need to go all in with a device like this. It's really the people, once they start developing more significant insulin needs, and particularly when they start getting fasting hyperglycemia, that's really when I personally start to introduce the idea of insulin pumps and everything else with those patients. Although I get them on CGM usually pretty quickly. I do love CGM.
In your study, was the bionic pancreas working only with insulin, or did it have the dual insulin and glucagon?
That's another great question. So this particular study, we looked just at the insulin-only device. We had initially planned on looking at the bihormonal, the insulin plus glucagon device too, but that one is not quite ready for IDE approval yet, so we had to wait. Eventually, I would like to look at that in more detail with the bihormonal device. I think that there is something to be said for having the glucagon to help protect against the lows. It helps the insulin be a little more aggressive in dosing when you have that rescue glucagon right there. At the same time, glucagon also, we need to learn more about what that's going to look like with CFRD because it can sometimes cause nausea in higher doses. Didn't seem to in our pilot, but stay tuned. I do think that the bihormonal device is going to be really interesting in this patient population.
Someone asked if you collect data on study participant perception of the device.
Thank you for asking that question. I actually deliberately left that out of the slide, but I'm glad you asked because, so we collected a bunch of patient-reported outcomes for this study, and we are in the process of analyzing it now. I did not realize how complicated it is to analyze PRO data. I will say, just having preliminary looked at the results, a lot of the patients in this study actually had very low diabetes distress at baseline, which was so interesting to me, and it was lower than what you would expect to see in type 1 diabetes. And I can't explain it other than the fact that most of them are my patients, and I just do a great job of taking care of them. What else would it be? So, but in all honesty, it's surprising, and I think that they started off in such a good place that and the sample was so small, I don't know that we're going to see a lot of improvement from where they started from. And so stay tuned on that data, but I also think what it has made me realize is that we just have so little real PRO data just in general in CFRD, and something that I'm going to be looking into more.
Someone asked what the insulin dose was after the intervention, and then how often glucagon was called upon, but I think you answered that. Glucagon was not part of the bionic pancreas.
Say it one more time.
So the first question was, can you remind us what the insulin dose was after
Yeah.
the intervention?
Yeah.
And how often glucagon was called upon? But I think you answered that.
So, those are great questions. So, the insulin dosing did not change. So they're basically their total daily dose was the same for before and after. We actually used, for the people on MDI, we used an InPen, which is an insulin smart pen, to capture all the dosing. And then, yes, and nobody needed any emergency medications during the study. That would have constituted a severe low if they needed glucagon at any point as an emergency rescue medicine, and they did not. And we did not look at glucagon in the device.
And then there's one last question so far. Thanks for the great talk. Because weight is the only input required to initiate the bionic pancreas, and because we are struggling to recruit physicians into endocrinology, after having done the study, can you envision a non-endocrine clinician initiating the bionic pancreas?
Another great question. I feel like I planted these. So the answer is that's the goal. That's absolutely the goal. So right now we're doing a study at MGH where we have endocrinologists, including myself, initiating the bionic pancreas both in person and only by telehealth in patients. And then we have another site in Colorado that is primary care physicians. And they are doing the same thing, both in person and telehealth. And the whole point of the study is to see if it matters. And do you need an endocrinologist to initiate this device? Because let's face it, there's just a lot of places in our country that don't have endocrinologists to be able to start devices like this. So I think that the hope is that yes, anyone would be able to start it.
Go ahead, in the back.
So the question was, how long did it take the bionic pancreas to learn and the algorithm to adapt to each patient? Yeah, so they were on the islet for 2 weeks. And the data that I showed you for our primary outcome, we actually used days 3 through 14 to give the islet 48 hours to adapt. And we did actually compare day 1 and 2 to the days 3 through 14, and the blood sugar was a little higher during that time while the system was learning, but by day 3 and on, it had pretty much figured it out. And the interesting thing too is the hypoglycemia was the same, both while the islet was adapting and then after.
Great. Oh, we have an additional question.
I'm still not checking. How physically active were your patients, and do you need to make any recommendations when you're first starting regarding physical activity that may impact that initial algorithm?
Yeah, that's a great question. So it was, how physically active were the participants, and what did we advise for them in terms of exercise? I will say that's very true. Exercise is probably the single most challenging part of using any kind of automated insulin delivery system, because you can't tell the device that you're exercising. And so, I would like to say that my patients exercise regularly, but I mean, it's hard, but I think, there were some who are pretty physically active. And so, for the most part, you can't really, you can have, we would say, if, like you normally would, have a small snack before, but, there's really not much else that you can do. With the bionic pancreas, you can change the target. You can go up, it starts at 120, you can go up and you can go down. So you can change the target if you need to, but yeah, that's the hard part. We did not actually, so It's a great point. We did not actually look specifically at exercise during this study, but it's something that I really want to do for the next one, because I think that's going to be really important.
So the pumps have activity. You can set an exercise setting on both the Tandem and the Omnipod pumps. So you can tell it that you're exercising.
Yes, this is true. So for the Control IQ and for the Omnipod 5, you can, especially for Control IQ, there is an exercise setting. The downside of that, though, is that the system, although it raises the target, the system will still give these little Control IQ boluses, and so a lot of people still struggle with that. Omnipod 5, I've only had maybe like 3 people with CFRD start the Omnipod 5, and so I haven't gotten a good sense yet of how it's going to work, but we'll see. We'll see. It's okay.
One last question. What, is this a single device, or is it,
Well,
is
it's
the continuous
CGM.
glucose monitor separate from the?
Yes.
It is, okay,
Yeah.
so it's 2 devices
It's
still.
the G6, the
Okay.
Dexcom G6.
All right, and so the patient is aware of their blood sugar even with the iLet?
Right.
Okay.
That's exactly right. So in most of the patients, 90% were already using CGM. And so it was really only, I think, like 2 people who were not. For the people who were not, while they were in usual care, they had a blinded G6 because we didn't want to do another intervention. Right. But they were unblinded with the G6 while they were on the bionic pancreas.
Thank you very much. Okay, so I just have a quick wrap up from the session. So we've heard that OGTT, while it is the gold standard, we know adherence is very low, and this is highlighted in quite a few poster presentations here at NACFC. So I'd encourage you to check out these 4 posters listed here for more information and strategies on what other clinics are trying to do to improve CFRD screening at their centers. And what Dr. Hicks highlighted is that reminders may help. So that's something that a lot of us probably can implement into our practice if we're not already doing. What Dr. Rabasa-Lhoret was going to present, amongst many other things, are that alternative screening methods are being used by many providers, and Dr. Hicks highlighted that as well. And the new Canadian guidelines will state that no annual OGTT is required if the A1C is less than 5.5%, and this is specific to stable individuals without known factors affecting A1C validity. There's also an interesting poster here at the conference that talks about predicting high glucose levels through voice characteristic analysis. So I'd encourage you to check that out as well. We've learned from Alexis and Andrea that CGM can help identify CFRD in people who may otherwise not be picked up through traditional OGTT testing. And it may also help predict the likelihood of developing CFRD over a 3-year window, which is very interesting, and I'm really excited for more studies on this topic. Also supposed to be discussed by Remy, oral anti-hyperglycemia agents may be considered for adults where weight and pulmonary decline are not an issue. And I believe this is going to be discussed further tomorrow in a session in the morning on type 2 diabetes and CFRD. There will be a talk on using type 2 meds for our patients with CF, which is really interesting and exciting. And then finally, technology is evolving, and using the iLet bionic pancreas does improve glycemic control with no increase in hypoglycemia, which is really exciting. And there is a lunch and learn tomorrow that talks more about diabetes technology for the CF team with, I think, a hands-on element as well. So that's Saturday at noon. You do require a ticket, but I know for a lot of these sessions, many people who have registered don't show up. So there is a lineup for people who have not pre-registered, and there's a good chance you'll get in. So for future directions, more studies and larger studies looking at different ways to screen for CFRD, and I think it will be interesting with these new Canadian guidelines that will be coming out if other clinics are starting to implement an A1C sort of pre-screen, whether they're missing any diagnoses as a result of that. I think definitely if we're starting to use oral medications more often, more studies comparing these with insulin specific to CF-related diabetes, bigger studies looking at the predictive value of CGM across different ages, because Andrea's study really just looked at youth. I think what everyone's kind of interested in and talking about is highly effective modulator therapy and how that might affect the risk of CFRD. And poster 580, which was discussed in a symposium session yesterday, talked about the preservation of beta cell function in people with CF who were on highly effective modulator therapy. So they're suggestive that there's some beta cell preservation. It may be minimal, and the thought process is that people with CFRD are unlikely to see major changes, but those who do not yet have diabetes, there may be a prolonged period before they develop diabetes if they're on modulators. And then larger studies of the bionic pancreas and other automated insulin delivery systems to hopefully improve the quality of life for our patients with CF. So thank you very much, everyone, for attending, and yeah, we'll see you around.